Hello, doctors. Are you ready to face the ultimate challenge? Imagine you are sitting in the NEET PG exam hall. A tricky pediatric question pops up and you solve it with confidence. Sounds amazing, right? In this video, we are diving into most high-yield pediatrics MCQs, the kind that can make or break your score. We will not only solve them together, but reveal the secrets of mastering pediatrics like a pro. Think you have got what it takes. Take the challenge, comment your score, prove you are ready to conquer the NEET page. So let us begin with the first question. The most common manifestation of congenital toxoplasmosis. The most common manifestation of congenital toxoplasmosis. A. Thrombocytopenia. B. Chorioretinitis. C. Hydrocephalus. And D. Hepatosplenomegaly. So the most common manifestation of congenital toxoplasmosis is the options are A. Thrombocytopenia. B. Chorioretinitis. C. Hydrocephalus. D. Hepatosplenomegaly. Now comment in the answer chat box what is the correct option here. So the correct answer here is chorioretinitis. This chorioretinitis is the most common manifestation of congenital toxoplasmosis. Now, what is the classical triad of congenital toxoplasmosis? It is chorioretinitis, most common, hydrocephalus, and intracranial calcification. The causative agent of toxoplasmosis is Toxoplasma gondii, an obligate intracellular protozoan. The transmission of toxoplasmosis is transplacental. Via consumption, primary infection may occur via consumption of raw meat or contact with the cat feces. This toxoplasmosis is extremely dangerous. The diagnosis, you can do serology, PCR. PCR indicates exposure and risk of reactivation. Tissue examination can be done for histology. Isolation of organism can be done in mice. Or you can do tissue culture. In CT scan, you will see multiple isodense or hypodense ring-enhancing mass lesions. MRI, it has a predilection for basal ganglia and it is more sensitive. So the most common manifestation of congenital toxoplasmosis is chorioretinitis. Please click the link in the description box to join the ultimate NEET PG Masterclass Breakthrough event. Most common cardiovascular anomalies in congenital rubella syndrome is A. Pulmonary stenosis, B. Patent ductus arteriosus, C. ASD, D. VSD. So what do you think is the correct answer? Congenital rubella syndrome, as we all know, it is patent ductus arteriosus. Let's see what the correct answer here. It is patent ductus arteriosus. The correct answer is B. The classical triad of congenital defect are deafness, which is most common, cardiac anomalies, patent ductus arteriosus, followed by pulmonary stenosis, followed by VSD, followed by ASD. So the most common is patent ductus arteriosus, followed by pulmonary stenosis, followed by VSD, followed by ASD. So the least common is ASD. Then cataracts will be there. Patent ductus arteriosus is the most common congenital heart disease with rubella, followed by pulmonary artery, that is pulmonary stenosis. Pulmonary artery stenosis. Congenital rubella syndrome refers to infant born with defects secondary to intrauterine infection or who manifest symptoms or signs of intrauterine infection sometimes just after birth. This is the most common serious complication of maternal rubella infection, which occurs when she gets infected during the first trimester. The most common complication is IUGR. Birth defects are uncommon if maternal infection occurs after 20 weeks. If it occurs after 20 weeks, birth defects are uncommon. The birth defects occur when it is in the first trimester. So the correct answer here is patent ductus arteriosus. You can directly WhatsApp me in this number 948365220 for any difficulties or whenever you feel anxious. So let us move to the next question. Click the link in the description box to join the ultimate 2-day NEET PG revision breakthrough blueprint masterclass. Apgar score 3 at 1 minute indicates A. Severely depressed. B. Further resuscitation is not needed. And C. Mild depression. D. Normal. Score 3 at 1 minute means it is severely depressed. Very bad prognosis. ABGAR scores are routinely assessed at 1 minute and 5 minutes, and every 5 minutes thereafter, as long as the resuscitation is continuing. The 1 minute score gives an idea of what was going on during labor and delivery. The 5 minute score gives an idea of a response to therapy, how the resuscitation is progressing, whether the resuscitation is adequate or effective, or it is providing any results or not. So the correct answer here is severely depressed. Let us move on to the next question. Where to look for preductal O2 saturation in PDA, patent ductal cytosis, in a 3-minute born infant? A. Fetal left upper limb. B. Fetal left lower limb. Fetal right upper limb. Fetal right lower limb. The correct answer here is fetal right upper limb. This preductal oxygen saturation is always recorded on the right upper limb. The left hand, however, has always been ignored as it was unclear. If the ductus arteriosus influences left hand arterial perfusion, if preductal saturation is more than 5% compared to postductal saturation, it confirms the presence of right to left shunt. Best area to check postductal saturation is the foot. Preductal saturation, fetal right upper limb. Now let us move on to the next question. Please like, share, and subscribe this channel and click the bell in the notification so that you get the notifications whenever I go live. Usually it is in the 7 p.m. in the evening, sometimes in the morning. 7 p.m. in the evening is a correct time. So even please hit the notification bell. The commonest indication for liver transplantation in children is A. Acute viral hepatitis. B. Biliary atresia. C. Caroli disease. D. Hepatocellular carcinoma. Commonest indication for liver transplantation in children, it is biliary atresia. Biliary atresia is the most common indication for liver transplantation in children. Children with biliary atresia who do not achieve successful drainage require liver transplantation within the first year of life. Other common indications are metabolic and inborn disorders, autoimmune and familial cholestatic disorders, and acute hepatic necrosis. So the correct answer here is biliary atresia. Please comment in the chat box whether these questions, what is the correct answer to this question. Molecular defect causing liver disease in Dubin-Johnson syndrome is A. ABCC2, B. ATP7B, C. ATP747A, and D. CFTR. Well, the correct answer here is ABCC2. The molecular defect ATP7A corresponds with Menkes disease, ATP7B Wilson's disease, CFTR cystic fibrosis, ABCC2 Dubin-Johnson syndrome. So molecular defect causing liver disease in Dubin-Johnson syndrome is ABCC2, codes for canalicular protein with AT binding cassette. It leads to mutation of multiple drug-resistant proteins, that is MRP2 receptor. Hence, there is a defect in transfer of conjugated bilirubin from liver to bile in Dubin-Johnson syndrome, ABCC2 Dubin-Johnson syndrome, ATP7A Menkes disease, ATP7B Wilson's disease, CFTR cystic fibrosis. Inherited non-hemolytic unconjugated hyperbilirubinemia is A. Rota syndrome, B. Crigler-Najjar type 2, C. Dubin-Johnson syndrome, D. alpha-1 antitrypsin. Crigler-Najjar type 2 is a inherited non-hemolytic unconjugated hyperbilirubinemia. Dubin-Johnson syndrome and Rota syndrome are inherited conjugated hyperbilirubinemia. In alpha-1 antitrypsin deficiency, the serum protease inhibitor alpha-1 antitrypsin is deficient and it causes conjugated hyperbilirubinemia. So the inherited non-hemolytic unconjugated hyperbilirubinemia is Crigler-Najjar type 2. So Crigler-Najjar type 2 is an inherited non-hemolytic unconjugated hyperbilirubinemia. Dubin-Johnson syndrome and Rotor syndrome are inherited conjugated hyperbilirubinemia. In alpha-1 antitrypsin deficiency, the serum protease inhibitor alpha-1 antitrypsin is deficient. It causes conjugated hyperbilirubinemia. Cardiac edema and neuropathy are seen in which of the following vitamin deficiency? A. Biotin, B. Thiamine, C. Pyridoxine, D. Riboflavin. So the correct answer here is B, thiamine. Cardiac edema and peripheral neuropathy are the features of beriberi which is caused by deficiency of thiamine, that is vitamin B1. Dry beriberi neurotic is irritability, peripheral neuropathy, ataxia. Wet beriberi cardiac is tachycardia, cardiomegaly, cardiac failure and edema. Diagnosis by erythrocyte transcriptase activity assessment. Complications include lactic acidosis and Wernicke encephalopathy in adults. So cardiac edema and neuropathy are seen in which of the following vitamin deficiency? A, biotin, B, thiamine, C, pyridoxine, D, riboflavin. So correct option here is B, ribothiamine. Cardiac edema and peripheral neuropathy are features of beriberi which is caused by deficiency of vitamin B1, dry beriberi, neuritic irritability, peripheral neuropathy, ataxia, wet beriberi, tachycardia, cardiomegaly, cardiac failure, edema. Diagnosis by erythrocyte transcriptase activity. Complications include lactic acidosis, Wernicke encephalopathy in adults. Which of the following is not seen in a child with cystic fibrosis? A. Sweat chloride test, concentration of 70 milliequivalent per liter. B. Hyperkalemia. C. Increase in immunoreactive trypsinogen contraction alkalosis. So the correct answer here is hyperkalemia. So what happens in cystic fibrosis? It is an autosomal recessive disease caused by mutation in CFTR gene, that is chloride channel on chromosome 7, characterized by widespread exocrine gland dysfunction. Patient with cystic fibrosis can present with contraction alkalosis and hypokalemia. ECF effects are analogous to patient taking loop diuretics because of ECF H2O Na plus losses and concomitant renal K plus H plus wasting. So it leads to hypokalemia. It is diagnosed by a sweat chloride test, pilocarpine electrophoresis, sweat chloride test, confirmed by genetic test is increasing chloride concentration more than 60 milliequivalent per liter in the sweat is diagnostic. Increased immunoreactive trypsinogen level can also be used for the diagnosis. This cystic fibrosis is a very important thing. It is an autosomal recessive disorder caused by mutation in CFTR gene chloride channel on chromosome 7, characterized by widespread exocrine gland dysfunction. Patient with cystic fibrosis can present with contraction alkalosis and hypokalemia because ECF H2O Na plus loss and concomitant renal K plus H plus wasting. Diagnosed by sweat chloride test, confirmed by genetic testing. Increased chloride concentration more than in sweat is diagnostic. Immunoreactive trypsinogen can also be used for diagnosis. The most common cause of HIV infection in newborn is A. Breast milk, B. Exchange transfusion with infected blood, perinatal transmission, D. Transplacental. While it is